Hello, Uganda. Good evening, and welcome to this edition of the Hot Seat on 933 KFM. I welcome you, our listeners across this beautiful land, the Pearl of Africa. My name is Patrick Kamara. Tonight, we are going to be super focused on health, the right to health, bridging gaps across other sectors to achieve equitable health for all. It's such a big deal because, health is wealth. If you have your health, then you can start from there even to create wealth. And so my guest this evening is a gentleman who understands this project, this subject very well. He's the program's director at CEHURD, Mr. Richard Muganzi. Thank you so much for joining us, Richard. Good evening, sir.
Good evening to you, Patrick. Nice to be hosted here.
So yes, here we are. We want to focus on health. What I know, for the last 15 years, CEHURD has focused on advancing the realization of the right to health. CEHURD is a civil society organization.
Sure.
But not every citizen understands what this right is about, the right to health. In your view, as Richard or as CEHURD, what is the right to health?
Thank you very much, Patrick. Like you've already mentioned, I'm Richard Muganzi. So when we look at the right to health as CEHURD, which is the Center for Health, Human Rights and Development, we see it broadly, and we feel that health, as provided for, is the highest attainable standard of living. And it can be from the physical, it can be the mental or the social well-being of a person, and it encompasses a number of factors that contribute to a healthy life. And so we see health beyond medical care because it has various social determinants that we believe are also important in determining the well-being of people. It could be housing, it could be education, it could be the environment, the livelihoods, among others, or even the safe waters. So health really is that which looks at the resources, the information, and the opportunities necessary to achieve one's high standards of living. And it should be available, it should be accessible, it should be of quality, and really acceptable to all in an appropriate manner.
I didn't know that's such a huge question that needs such a huge response. And it is touching on housing, it's touching on food, it's touching on environment, it's touching on many things.
Sure.
So when you look at Uganda,
Yeah.
where do we stand in terms of all those factors that determine health? Where do we stand? Because environment, we seem to have destroyed it. These days, when you walk on the streets of Kampala with the pollution that we have,
Yeah.
and all these vehicles that are emitting all these gases, and you wonder, are we even living in a healthy environment?
Yeah, thank you. That's a very good observation, and you're right at it. Definitely, we are all responsible as individuals because the starting point is government, of course, because it is them that has the mantle to design the policies, the laws, and to ensure that these are upheld. But from the individual point of view, we have the responsibility to see that every individual knows their responsibility and role. And so we have to make sure that everyone understands what it means for a healthy life to be lived. Because when you educate people, you must bring in component of education, because the doctors that are being educated also have something to extend to our understanding. The water that we drink has to be as safe. The food that we eat, we must be able to know that you can avoid obesity, you can avoid diseases. And so the many times when we see an unhealthy environment or an unhealthy living, it is because the individual has not taken the responsibility. At the moment, we are living in a world where we're talking about self-care. So really, gone are the days when the blame only goes to the health sector, because actually the health sector receives patients. But before the patients get there are so many preventive ways.
So, Richard, what you're telling me that for you to live in a health environment, you're better off if you're educated, you're better off if you are responsible, because you'll understand what to eat, you'll understand what to do, but also you'll take the right decisions to keep healthy.
In a way, yes, but not necessarily. What I'm trying to say here is that health is multi-sectoral. And so we have to know that every other sector contributes something to a healthy living. And so if those who are in the education and sports ministry have something to do in contributing to healthy living, let them do it. Those who are in the Ministry of Works to ensure that there is good transportation to health facilities, let those do it. Those who are in the Ministry of Water and Environment can have what they can do, and each of us has something to contribute to ensure that it is not left only to the health facility, because there are so many non-medical approaches to having a healthy living.
You know, I'm saying enlightenment or education or sensitization in helping you live a healthy life. I'm giving an example. I was in Rakai sometime back, and then there are children who are malnourished, and there are those who are not. And those who are not malnourished is because their mothers had been sensitized on what to cook, on what to mix. And sometimes they are giving them food items that are readily available within the courtyard, but only that they did not know how to mix them. So there was a civil society organization like yours was teaching them to cook what they call the chitobero, and you'd find there's a remarkable difference of a child who has taken a chitobero and the one who has been eating just anyhow. So information was helping for people to live a healthy life.
I agree with you, and of course, as said, we try to make sure that one lives their health, not necessarily because of any limitations of gender or way of socio-economic living or any way of education. And so I was trying to bring it from the angle that, well, it is each's and everyone's responsibility from a multi-dimensional approach, from a multi-sectoral approach. But when you bring in specifically the aspect of education, yes, definitely, a well-informed person, a well-sensitized person has to live better. You could even take it in an angle where you look at the Gao child. The many Gao children who have been retained in school are usually living a better lives as themselves, but also their children, because they take the decisions at the right time, their bodies are prepared a lot better, and they have more information on how to live best, and can even have an income that can enable them to look after their children.
There are quite a number, I suppose, of dividends to a family if a girl child attains education, health dividends as well, right?
Very true, you're right on that.
So health in Uganda and world over is progressively realized, yet realizing justice stroke equity in health system remains a big challenge and close to impossible. So Richard, what are some of the equity and justice matters that one needs to pay attention to in the healthcare system?
Yeah, you see, the healthcare system is a very tricky area for many. And when you look at health in general, you realize that there is need for society to be able to consider itself based on a number of factors. Like, for example, you have the Abuja Declaration that required that health should be apportioned a budget of 15% of the national. And this is not something that is easily achievable. But in order to achieve it, it is important that we have to engage each and everyone to coordinate the financing structures we have, to coordinate and pool the resources that are available, but also to ensure that there is accountability. Accountability meaning that the communities themselves can be able to have the empowerment they need to hold the duty bearers accountable, but also that they're involved in the programming, that they can be able to plan together with the implementers, but that they can also be able to tell stories of change and also influence policies. We have had communities that we have engaged in research, for example, on teenage pregnancy, and the findings from this have informed a number of policy decisions and reforms. We have had a number of cases in courts where a court has declared itself on a number of provisions that are not necessarily within our constitutional provisions, but can now be able to hold others accountable, but also to see the right to health as justiciable, because we don't have clear provision of the right to health in our legal frameworks, but we have bits and pieces that can enable us to hold government accountable. And so all around the world, we see the right to health explicitly stated, unlike in ours.
In your submission, you talked about the Abuja Declaration, where Uganda is the signatory to that mandates Uganda to put about 15% of its budget into the health sector. Do you think this is plausible, considering the competing priorities of Uganda? 15%. I'm asking because just last budget, we are at 4%. By the grace of God, now Uganda is around 8%. But is it achievable to reach 15%? Is there a country that has made 15%?
I think we need to be very strategic on how we get there. Because, like we are saying, you cannot have an entire 15% of the national budget and allocate to a single sector in a country like Uganda, unless really we have this gold and these oil resources. But that being the case, more importantly, we have to see what are those fractions of contribution from the other related ministries that can be able to channel a percentage of health-related programming that can contribute to the entire health budget of the country. Because, like we mentioned, through the Ministry of Transport, we can have a budget coming through for the infrastructure. Through the Ministry of Water and Environment, we can have a budget to ensure that we have safe living.
Because it's inextricably linked.
Yes.
So
looking at the 15% as purely coming from the Ministry of Health might not be achievable. But if you look at it from various angles, be it the Ministry of Trade and Industries,
then it can even go beyond 15%.
It can.
But I wonder whether the framers of that declaration were talking about health as health, or health, that is intertwined with other sectors, education, trade, and infrastructure and stuff like that. Because if that is the case, then we hit the target long ago.
Yeah, I think the framers are very ambitious to look at the health sector as the health sector. But then as programmers, we believe that that might not be achievable, and we have to be innovative so that in our various contexts, we see how to achieve it, but in a manner that is context-specific and tailored to our own purposes.
Mr. Richard Muganzi, there's one thing I've noted in Uganda is that, God forbid, you and I and everybody who's listening, we are all in perpetual vulnerability. Should you or should your loved one fall sick and be admitted, you can actually even go back to the village and sell your land.
Sure.
That healthcare is so expensive. I don't know why. Even a hospital that is not so up the top tier, still you cannot afford 1 week in it. And it makes all of us, especially when you hit 40 and above, you are worried because you become a candidate of non-communicable diseases, and you're like, 1 week alone, Richard, will take you back to the village.
Very true.
What causes that? What explains that?
I think when you do a comparison with other so-called welfare states that ensure that really there is universal health coverage, that ensure that insurance is not so much in the hands of the rich, but can also be in the hands of the poor, creating innovative models of insurance saving for farmers, for those in the informal sector. Really, it is the way to go. And we don't really want to feel that we are unfortunate, that we can't get there. But I think that there have been strides. At the moment, we have a bill in Uganda that has not yet been assented to. But we believe that if you look at the national financing strategy of Uganda, which is ending this year, I hope that we are going to get into the third stage as well, it clearly has a roadmap on how we can get to universal health coverage, to reduce on the out-of-pocket expenditure, to reduce on the disease burden, to improve on the risk that people who are not protected by some very good welfare systems can be able to access services. So I think that the country has had so many infrastructure developments and is now at the level where we're going to go into the human resource itself. And for us as civil society, I think that's the role we have to play and say, government, here are the dividends that can come from having a good human capital. So there's human capital development strategy. There are a number of indices that indicate that we are getting there. And what is important for us is to keep on demanding from government that when we have a healthy population, then the economy is also going to improve. And for CEHURD, we create this linkage and the nexus between health, the human rights component, and development.
All right. Mr. Richard Muganzi, Programs Director at CEHURD, we're going to take a break. When we come back, we'll be looking into, I understand it's the second Uganda National Conference on Health, Human Rights and Development. What does that entail, and what should we expect from that? We'll be right back.
Hot Seat. Hear the real story behind the story. Coming right at you. Only on 933 KFM.
Welcome back to 933 KFM, and this is the Hot Seat. My name is Patrick Kamara. My guest tonight is the Programs Director at CEHURD, Richard Muganzi. and we're discussing health matters. You know, during COVID-19, because so many people got affected or infected and they are in hospital and fighting for their lives, we realized that a lot of money was needed to treat an individual. And that's how everybody thought that COVID was too expensive to treat. But the truth is, in my view, Richard, that hospital expenses have always been like this. But because at this time now almost everybody was in hospital, we got to know. But people have been suffering. Right now, whether it's a minister or a member of parliament or a top government official, if you fall sick, you need government to help you. Either in Uganda or maybe in Nairobi or in India. On your own, you can't. There should be some innovative ways on how government can have a universal health insurance for Ugandans. I'm thinking probably embed some kind of a tax, a certain percentage, which is specifically going to care for people, you know, to be able to pay or cover their medicines. And there are some countries doing that.
Of course, it's all about creating fit-for-purpose approaches within each context. Like I've said, in Uganda, we have our own specific concerns, we have our own limitations, but we also have our own opportunities. Like, for example, you can find that the third-party insurance or tax can be able to contribute to the national health insurance. And so you find telecommunication companies, for example, having levies of people and putting it in a pool that turns into some kind of insurance for health. So it is all about how we can utilize all these approaches within our country and create a complement to the bigger national framework, which might take long, or if it takes a short time, but at least that we have a bigger buffer than only looking at pointing fingers, but necessarily looking at whatever opportunity there is for us as a country and citizens in general.
I've always wanted to know, how do civil societies like yourselves, CEHURD, work in collaboration with the government on matters of health? Because I know sometimes you do a lot, but is there some kind of coordination? And, you know, how do you collaborate?
Thank you very much. And it is interesting to note that increasingly government has engaged not only civil society, but also the private sector, the media, the academia. We see a lot of collaboration, especially in the Ministry of Health. We have been very privileged as CEHURD to be that legal and human rights-based organization that has engaged very well with the ministry. And as we are, for example, this time around working on having the conference, the Uganda conference, national conference on human rights, on health, human rights and development, we see that this partnership has been very much fronted by the ministry. And we almost sit in the back seat and enjoy the kind of capacity and the kind of influence the ministry has in advancing many of our observations and findings from research, findings from communities. We do a lot of empowerment programs. We do a lot of litigation even against government, but we still get the support of government because we don't litigate against government because we are enemies of government.
So let me ask, when you talk about the health right, health as a right, and if you find yourselves in conflict or in a collusion cause with government, where and sometimes where do you find the problem for that right not to be respected or observed?
I feel that government is not just about the structures, but it's also about the individuals, it's about the laws, it is about the various frameworks. And so it is a complex system that one needs to understand, that even at times when the blame might go to government, it might also have a component of failure to have compliance amongst the population and therefore requiring a bit of enforcement. So many of the challenges usually are not because the government systems are rigid and failing, but also because there are so many complexities to maneuver because government is very organized and you have to deal with the government in a manner that can be able to ensure that no one is left behind. So when you look at health promotion and health outcomes, we are looking at the ability for everyone, irrespective of their background or status.
If there is a case of, let's say, medical negligence or somebody has not been taken care of so well in a public hospital, how does CEHURD or any civil society organization come in? Because I remember there was a case in Nakaseke, if you remember. How do you handle such?
Yeah, there are many such cases in Mulago, cases in communities like Nakaseke, the one that you've mentioned. Of course, these cases happen over time. And 15 years ago, it was very difficult to maneuver a case through the court system on the right to health, because by then the jurisprudence was that people felt there was no clear provision as a basis to have the right to health as judiciable. And so the justifiability of health as a right has been of recent because of the pragmatism in court and against the objectives within the Constitution. Judges have pronounced and said, you know what, yes, government has a right, has an obligation to safeguard this right for everyone. And so, like the case of Nakaseke, this was a case of obstetric care in hospital, and the mother had died just because of cases of negligence. And so court was strong on this and said, yes, really, while we realize that there are some bit of gaps within the legal frameworks, we hold this as a very clear ground that a right was violated, to access right for this particular mother. And so that has made a clear statement, and from that point on, working together with government, we have been able to identify for each and every policy or law that is going to be put in place. We are able to also have an opportunity to have our contribution based on the experiences we get in the communities, based on the kind of insights we get while through the court system, but also based on our own programming, the needs that we see, and the benchmarking we have with other jurisprudences across the world.
If you go to look at some of the medical facilities we have, public medical facilities we have, maybe the health center 3s, health center 4s, you'll find, yes, the structures we have them, but in some cases the medicine may not be there, and in some cases the medical personnel are not there. But in some cases, the patients are so many that some of them are sleeping on the floor.
Yeah.
And as a right there, you can actually see that their right there is being violated. And I went to a hospital years back, I'm sure now it could be better, where I could see, a charcoal stove just near the entrance of an operating theater, and the charcoal stove was used to, boil those equipments because the autoclaving machines had died long time ago.
Yeah.
And I mean, isn't that really all those things showing the violation of a health right?
It is indeed. And of course, there are so many factors that we have to look at, and there are so many things that need to be addressed. First of all, we must be able to appreciate at the moment that much of the health budget has been coming from development partners, and many of them are pulling out, especially from the United States, and this causes a number of budgetary deficits on the health sector. When that happens, it means many of the programs, many of the procurements, many of the logistics, the human resources that were being funded through these avenues are actually getting out of the system. And so it requires us to think closely, for example, on what government is doing. One of the things government is promoting these days is integration, to see how do we integrate many of these drop-in centers, many of these youth spaces that have always been separate from the mainstream, come all together and see within the current challenges, how do we address each other's needs and ensure that no one is left behind. At some point in time, we have to see that we take on the responsibility, even without resources that are from external. How do we use the domestic resources? And so when we hold an opportunity like this one, where we have the Uganda National Conference on Health, Human Rights and Development, we want to bring together all actors and say, from all our various sectors, from all our various capabilities, from all our various learning, from all our knowledge, what are the challenges we face? How can we contribute to ensuring that at least there is a seeming good path towards having the required health outcomes? Maternal mortality has to reduce. We have to see to it that infant mortality reduces. There are so many things, and we are happy to see that when you look at the growing trends on maternal mortality, there is a time where we had very overwhelming numbers of women dying out of every 10,000. At the moment, the number has gone to 170 or even less. Recent studies are even indicating about 153 per 100,000. So these are really very good trends, and I think we need to hold those that we have to hold accountable. But at the same time, we also have to appreciate that something has been done.
Isn't it very suicidal for a government like ours to give the responsibility of taking care of people living with HIV and AIDS to other foreigners to do that? Because almost 90% of the money that is used in the HIV and AIDS care is given by foreigners.
Yeah, I look at it from the angle of learning, because I have been endowed with a bit of years, and I know that back in the 1980s, when we had people that are living with HIV/AIDS, we would think they are bewitched. So over the years, we have realized that actually someone is not bewitched. We know why people get HIV, and at times people think it's out of promiscuity. Then we have also learned, no, at times there are those who are born with the disease. And so it is about now knowing how best to handle these situations. Over the years, we have realized that actually this is a learning curve. While it is clear that we have to be the ones to nurse our own wound, it was important for us to know how did we get the wound anyway. So I believe that we are at the point now where government is taking full responsibility. It might be a bit too late because also the funds are running out that are external, but we believe also that there is a bit of approach by the National Planning Authority and all the organs within government to repurpose its resources and ensure that this can be handled. It is an awakening call, and I think everyone is at it.
Mr. Richard Muganzi, Programs Director at CEHURD. We're going to take a break, and the hot seat will be right back.
933 KFM. The hottest debate on all relevant topics live on KFM's Hot Seat tonight. KFM's Hot Seat covers all the relevant topics every weekday, 7 to 8 p.m.
It's the hot seat. My name is Patrick Kamara. My guest this evening is Mr. Richard Muganzi, Programs Director at CEHURD. You know, there's something that has always baffled me in matters of health, because this country is largely a very young country in terms of the demographics. The majority of the people are young. But then there's this something called, in the delivery of health services, called the youth corner. And I'm wondering, why do you always want to serve the biggest percentage or the biggest demography of your country? You want to serve them in a corner. Isn't that violating their right?
Yeah.
That should be the one.
Definitely. You realize that the corner itself has reasons why it is a corner, and there are youth who don't necessarily have to go in a corner if they have the general health-related issues. If one has malaria, if one has a headache, there are no specific issues that require them to get to a corner.
Oh, there's something that takes you to a corner.
Yeah, but
okay,
when someone goes to the corner, it means that, first of all, they may require a bit of sensitization that is not appropriate for the general clinic, for others to hear, the general OPD, but that require youth to get to their corner and understand, for example, their body. How does the body transition when you're an adolescent? What are those changes you see in your life? What are the sicknesses that are specific to you because of your habits? If you're maybe using drugs, if you're getting infections, if you're in a way suffering from certain diseases because of your irresponsibility, the kind of information you get is not the information that you'll get from the OPD. It requires you to get to the side, and at times it goes personal, that it's not about talking to thousands of people, but it may be about talking to the individual, a bit of psychosocial counseling. And so that really requires someone to be in camera so that they get a very focused support that appreciates where they're coming from, where they're at, and be guided on where they
In some cases, these are sexual and reproductive health.
Exactly.
Or maybe sometimes also could be issues of drug and alcohol abuse.
Yeah.
Okay.
So that youth-focused corner is really to empower this person. At times you realize that they're so disempowered that when you talk about this issue in the general public, they actually shy away because they feel you're exposing them. But when they're in the corner, then they feel empowered. You target them, you empower them, orient them, and before you know it, then they're also able to work with the other peers and educate them and even spread the same message out there that enables them to get out of their predicament.
My colleague and I did a television documentary entitled Hooked. And Hooked was looking at young people who are actually hooked on the drug, alcohol and especially drug abuse.
Yeah.
And what we're able to see is very scary, that this country seems to be seated on a dormant volcano of drug abuse. It's going to explode, Richard. I don't know how far, as hard have you been able to look at mental health that is brought about by alcohol and drug abuse, because we seem not to have realized it, but it's going to hit us hard.
You're right. CEHURD very much works in partnership. We have partners who are very good in these areas. I don't want to mention a particular one because there are many, but at least what I know is that those that are in that area are people that we work with very strongly. As CEHURD, we have a lot of strength in advocacy. Where it requires advocating, we have been able to advocate the reforms in laws and policies, but also where it requires to partner. When a call comes from a development partner, we are able to.
But it's hard, and all actors in the health sector. Yeah. Do you appreciate the problem of mental health as brought by alcohol and drug abuse?
Definitely, we do appreciate it. Statistics speak very clearly. Like for, they say every 10 people that we see around moving in the country, one has some kind of mental problem. In Uganda, according to the research, that's not a very small number, because on the streets we see thousands of people. So it means every 100 of those thousands has a mental problem, or a mental disorder, or you want to call it a depression. And therefore, it requires that when we are looking at the well-being of society and a young society that we have as it is in Uganda, it is important to understand that at every point their mental well-being is critical. And if that is not looked into, then it is likely that also the decisions they make are not necessarily going to be the best or in their best interest. And as such, therefore, requiring us to give importance to the component of mental wellness in all that we program about.
I want you to speak a little more with clarity on the second Uganda National Conference on Health, Human Rights and Development. Exactly what are we talking about? What will it address? What do you want to come out of this?
Thank you, Patrick. All these issues that we've said here are actually pointing to one fact that a lot is happening out there, and it requires that there is a space in which we can be able to deliberate about these issues. We have put in place a biannual conference, and this conference is the Uganda National Conference on Health, Human Rights and Development. The first one was held in 2023, and so this year, 2025, we have the second, and this second one is actually looking at the right to health, bridging gaps across other sectors to achieve equitable health for all.
And when is it?
It's going to be from the 3rd of September to the 5th, but we also have a component of a pre-conference, and in this pre-conference we are going to look at the issue of the youth. Like you've mentioned, we have what we want to call the youth town hall with our various partners to see how the youth can be able to bring out these issues and engage with the policymakers like parliamentarians and forge a way forward on how these can be addressed. So we believe that the conference, the one of its kind, has not been thought of by many, but CEHURD has thought it very important that it is put in place. We are looking at least 4 major tracks that we want to look at from the angle of the social determinants of health. So because many people focus on health service delivery and healthcare, we believe that there is a tendency to neglect the social determinants of health, things that we believe are more pertinent when it comes to addressing the challenges in health. And so the first track is looking at the social determinants of health relating to sexual and reproductive health and human rights. But we're also looking at social determinants.
You think like poverty?
Well, Poverty is another area that comes, say, from the angle when we look at models and approaches of multi-sectoral collaboration in addressing social determinants of health. Because there are very many aspects about socioeconomics that are not necessarily health, but are coming from other multi-sectoral angles that you need to address the social determinants of health. A poor person cannot easily access a service. If it is, like, for example, surgery, they'd prefer to rather go and die because they have no source of getting treatment. If we also have social determinants for non-communicable and neglected tropical diseases. We have people like, for example, who are suffering from elephantiasis. We always see them with the buckets on the streets begging to be assisted. And rarely do we see them.
There's severe cases of elephantiasis in Kamwenge district, and in particular, and I've never known why, but in some, not in entire Kamwenge, but in some sub-counties. I don't know whether it is because of the volcanic soil where they dig, or maybe there's a particular vector that brings the disease, but I don't know whether you, as health players, have been able to look at Kamwenge and elephantiasis.
Not particularly as CEHURD, but I think we are open to such kind of insights and see what does that mean for us. And if there are opportunities of research, we always tap into them. Now, this has been raised. We never know how many people are listening to this. They can say, oh, yes, we know about this, and they can reach out and you see how we can put up a combined effort. But also, we go to addressing the social determinants of health for communicable diseases as another track. So we believe that when we look at these four major elements, at least we are going to be able to get to the gist of solving a number of problems. We have the opportunity as CEHURD of having the Prime Minister's office take lead as chief guest in this. And we really call upon every other person, the actors, to join us in the private sector, academic institutions, to see how we can tease out many of these issues and are able to address the challenges that we face.
How are the elderly in Uganda accessing health services? I know there's a social assistance grant for the elderly, which is maybe very little money, but I think they are in a very peculiar kind of situation. In Uganda now, we need to pay particular attention to the elderly.
Yeah. Our strategic plan as CEHURD looks at a number of people and groups in their various circumstances, beyond the youth, beyond the women, beyond the refugees. It also goes into the elderly. And we also try to ensure that while people have their special circumstances, that when we are engaging with the health systems, because we do a lot of what we call health system strengthening, we bring out the predicament of the various persons that have challenges beyond the mainstream. Each and every other person who is going to get to that age of adulthood, we definitely face a number of challenges because the organs and the systems are kind of failing. And so this is something that is critical when we come to health service provision, and it needs to be advocated for a lot more. While many actors may look at diseases, I think we also have to look at age, not only for the young, but also age for the elderly.
All right, Mr. Richard Muganzi, Programs Director at CEHURD. We're going to take a break. When we come back, I would want to know how CEHURD is working with the communities, in the community participation in the health sector, but also, if my producer chooses, he will open the line so that we can have people who are listening also have their say in this program. We'll be right back.
Okay.
933
KFM's Hot Seat. Hear the real story behind the story. Coming right at you. Only on 933 KFM.
Welcome back to 933 KFM, and this is the Hot Seat. My name is Patrick Kamara, and my guest this evening is Richard Muganzi, Programs Director at CEHURD. Well, you were still explaining about the conference, and I can imagine people listening to you perhaps would want even to take part, and you're still making a case for it. So how do people you talked about the dates, the 3rd, I think, of September, right?
Yes, the 3rd to the 5th of September.
So how do they get there? And
Right.
where?
Yeah. So the event is going to be at Mistil Hotel in Kampala, and registration is ongoing. You can register online, and if you want, you can look for UCHD 2025 as the easier way of getting
UCHD 2025.
UCHD 2025.
Okay.
And we also have a website of uchd.ug. So you will be able to access a lot of information about this conference via there. If you want to write an email, you can also write uchd@CEHURD.org.
And all that is in uppercase or lowercase?
All of them are in lowercase.
Okay.
And CEHURD is CEHURD. So registration is open. You can register for a pre-conference at $120.
Wow.
Yeah.
That's quite some money.
Yeah. For students, for the main event, you can register at $100.
Okay.
For the nationals who are adults at $250. East African community, well, that is $300, and for the internationals, it is $350. Of course, we have already had registrations from many of these, and we hope to have even a lot more. Those who want to come and exhibit, we have booths. So a booth goes for $1,000 US, and then a table still for exhibition is half that at $500.
Okay.
But we can be approached to have more discussions on the partnerships and engagements on how we can go with this. So we have had various partners who have come to us and say, oh yes, we have 10 people who are coming. How do we go around this? And we have been able to determine how to work with them. And so we call upon all those that want to be part of this to really use these channels. During the same event, we are celebrating 15 years of social justice in health. And so we are happy to have been around for that long. And we are also launching our 10-year strategic plan, which is beginning this year, 2025.
Okay, let me, after that explanation, let me now bring in some people who have been trying to get in touch. I have a call online. Hello.
Yes, Mr. Patrick.
Good evening, sir.
Good evening, and thanks for the show.
Your name and where you're calling from?
You're talking to Ekode, and you're live and clear in Seta.
Ekode in Seta. Go right ahead, sir.
Yes, I want to thank our guest for the insight it's giving us.
Thank you.
Actually, I'm so grateful to hear that there's such an NGO and the Minister of Health. Now, on such a national media, you have been always complaining about lack of drugs in hospitals. My issue is, if I report to your office, what impact are you going to do? Since the people concerned are also in the public offices. Thanks for that, sir.
Okay. Thank you very much there. Michael Inekode says if there's something he sees, if he reported your office, what would you do?
Yes, thank you very much for that very nice question. Yes, there are a number of reports that come to our office. What people don't know is that we don't necessarily have to come to the forefront. So we have assisted very many people who have had their cases heard in court. We have had cases of mediation with the health facilities where people have faced negligence from health service providers. We have even had compensations from certain hospitals for having botched surgeries or having not appropriately offered the services that offer for various clients. So we are not, like, I tended to feel that he thinks we are government. We are actually not government, but we work with the government.
Okay, let me take another caller online. I have a caller. Hello.
Kamara, you're live from Busega.
All right, go right ahead. This is Juma, right?
Yes, I'm the one, Papa.
All right, go right ahead, Mr. Juma in Busega.
Otherwise, the first place I would like to give appreciation to the gentleman in the studio with you.
Thank you.
And then my insight is about, are they only in Kampala Central here or they are countrywide? If they are not countrywide, they should extend their branch also to maybe district. Because me, I come from Nebi. that all of us, we acquire their services. I thank you so much.
Juma, you want them in Nebi?
Yes, I need them there.
Apoyo, Matek.
Apoyo.
Yes, Juma, thank you very much. Actually, we have what we call the legal aid clinic, and the legal aid means that we are offering legal services for free. And so people should not really fear to come to us. And one of the best way they can reach us is to use a toll-free line. The toll-free line is 0800, that is 0800 3000 or 300044. So whoever feels that they have a health challenge and they want to approach us via our toll-free line, the legal aid clinic is always available to receive you within working hours, Monday to Friday. So call that line 0800 300044 and we shall be able to help you.
All right. Okay, you can keep those calls coming in, and Richard will definitely be able to respond to you on the health matters. And but I understand you talked about community participation.
Yes.
Exactly how?
Yeah, communities are very critical because whatever it is that we do it for these communities. And so, like I said earlier, right from the point when you are identifying a community problem, it is important that the community is part and parcel of identification of that problem, because it is them that you're going to serve. Then when you are designing a program, it is important that communities are aware of the program and can contribute to the solutions and the plans that you are developing for it. And when you are implementing together with them. One of the things we have found, for example, is what you could look at, the mosquito nets. You find that people get mosquito nets and they use them for fishing, they use them for poultry, they use them for collecting scrap in plastic bottles, and you're like, this is a government resource. It has cost a lot of money for the taxpayer so that we can prevent malaria. But then why is it that actually someone in the community is using this as a curtain, say, for their toilet? And usually it is because engagement of the communities has not been to the level where it has to. And at times we don't understand exactly what their need is, and so you give them as much of a health product or commodity, and they don't know how to use it, or it's not exactly what they need.
In most cases, I don't know what brings this, a government program or policy of distributing something free, especially on the health side. It always find pockets of negativity. I mean, let it be, for example, vaccination. Or people will talk against it, and they will think no. And I will tell you, we can't sleep well in these mosquito nets, or something. I can't breathe, something like that.
Yeah.
Is it because it's free?
I think it goes back to the same question I've said. So when you are giving this mosquito net, what kind of house are these people living in? What kind of weather do they have? What kind of material is this mosquito net? And you may find that others would prefer, for example, to use an insecticide than an insecticide-treated mosquito net. Maybe others are asthmatic. So there are so many factors, and that's why we are saying community participation is important in designing, or first of all, understanding the problem, designing the solution, but also in implementing. So we believe that it is quite critical, and this also goes a lot with the research. So understanding where has the intervention started, what is the baseline? After its intervention, what has happened, and how do we document the results achieved, and where do we want to go? In all this, CEHURD has been working with the communities because we know they are central in the advancement of their own rights. And so even the Constitution of Uganda plays much of this in its provisions, ensuring that people have entitlements. So we cannot implement because we have very brilliant ideas in our heads. We have to implement because there are those for whom the rights are being defended, and they have definitely to contribute to the design of programming.
So I want to thank you so much, Mr. Richard Muganzi, Programs Director at CEHURD, for the information you've given us. You have definitely added value for our understanding of the health sector on this very platform. And as we conclude, I would want to give you another opportunity to give us your concluding remark.
Thank you very much, Patrick, for the opportunity you've given me. Dear colleagues, I am happy for you all listeners to have been there listening in. This is to inform you that as CEHURD, we are here to serve you, and we are very happy to bring everyone on board. Like you know, the reason why I've come here today, beyond the communities that have called upon to use our legal aid clinic and those that have called as partners to engage in our programming, we really want to call upon all of you to come and attend our Uganda National Conference on Health, Human Rights and Development. This is a very good opportunity. We call it CEHURD 2025. You can search it everywhere online. It is available. Come and join us. Be with us. We have a lot to share. We have a lot of opportunities. And we believe all together with the government, private sector, we are going to be able to change all these predicaments we have in the health sector.
But there's something very quickly we forgot, and that was the issue of gender-based violence. Sometimes people also, their health is affected by GBV.
Yeah.
Do you address that as CEHURD?
We do, and there are various forms of gender-based violence. These days we've been working a lot on intimate partner violence, a very silent killer in our homes. Many of us have intimate partner violence. We don't get into it. We have technology-facilitated gender-based violence. It is also on the increase. So we are addressing it in all its various forms as it keeps unfolding.
Mr. Richard Muganzi, Programs Director at CEHURD, I want to thank you so much. You've been phenomenal. This is something that you know just like the back of your hand. We thank you. We're looking forward to that conference and to see what is going to come out of the conference. We hope it does hit the mark that you want and achieve all the objectives of the conference. And that brings us to the end of tonight's edition of The Hot Seat. Join us again tomorrow, same time, same station. Good night and God bless you.